Hi, everyone. Give us just a few seconds to get started and get all that audio connected. My name is Kayla Fulgenetti. I am the Senior Director at Elephants and Tea. So excited to welcome everyone to session 3 of AYAO Power. Very briefly, POWER is our adolescent and young adult oncology program for oncology workforce education and resources. This is a year-long education program for professionals, and we are very excited to be bringing the next session to you this month. Just a couple of very quick housekeeping for everybody. This talk itself will be about 35 minutes or so long with time for question and answers at the end. So please feel free to drop those into the chat or the Q&A box. All of that will be up and going. You are also welcome to have any kind of conversations or hellos in chat as well. We love to see that and that engagement. We are, again, just excited to be here, and I am going to toss it over to Dr. Mike Roth to introduce our speaker for today.
Great. Thank you so much, Kayla. And we have a wonderful speaker on a really important topic today that when we actually ask our trainees and our providers what area they know the least about in AYA oncology, it is always sexual health. So please join me in welcoming Dr. Sharon Bober. She is an international expert on sexual health and as it pertains to AYA oncology care. Briefly, Dr. Bober is a senior psychologist at the Dana-Farber Cancer Institute. And she's an associate professor in the Department of Psychiatry at Harvard Medical School. She's the founding director of the Sexual Health Program at the Dana-Farber, a multidisciplinary program that provides care for survivors of adult and pediatric cancer. Her research efforts include a focus on developing sexual health interventions after cancer treatment, and she is really internationally known for her expertise on sexual health interventions and care and assessment. I've had the great privilege of working with Dr. Bober for the past few years, specifically on identifying appropriate patient-reported outcome measures for this population. We're really in for a treat, and just really appreciative that Sharon has joined us today. So on that note, I will kick it over to you, Sharon, and thanks so much for joining us and educating our community.
Thanks, Mike. It really is. It's really my honor to be here with you all today, and I'm excited to get started. So we will just dive right in. This is my disclosure and disclaimer, and again, really want to underscore that I will be drawing on some data talking about cisgender men and women, but very much want to appreciate that folks have different gender identities and may use different pronouns than some of what I refer to in the presentation today. So in terms of where we are, in terms of the objectives, I'm going to try to fit a lot in a reasonably short period of time, but I really want to sort of invite us to think about sexual health from a biopsychosocial perspective. I'm going to really talk about some of the basic kind of personal and systemic barriers that we often face in terms of dealing with sexual health. Very much want to give you some concrete tips and kind of framework for really how to start the conversation and address common problems that we see in our survivors, and really sort of think about the kind of resources and strategies for how to address and enhance care for our patients and survivors who very much are in need of support. So, before I really get started, I want to just pause and invite us to sort of consider what is sexual health. That may seem obvious, but it may not seem obvious, meaning that especially in a medical context for most of us, most of the time, our information, education, training around sexuality is really connected to disease, infection, and managing risk and danger. So whether that's, managing STIs, whether that's a question of unwanted pregnancy, whether that's a question of, is it safe do I need to use a condom? Can I, pass fluids with, to my partner? But it's really very much in a kind of pretty narrow perspective that most of us ever hear about sexual health and sexuality. I want to acknowledge my own initial training as a clinical psychologist who did a PhD in a program that was very developmentally focused as well as clinical. In my undergraduate years as a psychology and philosophy major, I heard nothing about sexual health. In my PhD program, I had a total of a 2-hour seminar from a visiting sex therapist in the community on my internship, my fellowship, and my clinical postdoc year, where we worked extensively with couples and families, no training around sexuality. So if this is something that mirrors your experience, this is to say, unfortunately, it's pretty normal. In the context of our patients and cancer in general, I also just want to acknowledge that the topic often feels like really the elephant in the room. It's a kind of a funny paradox because we live in a culture that is obviously saturated with sex and sexual images, but I would argue that we have very little real conversation about real sexuality. I think on that note, it's often confusing for patients and providers about who's even responsible for sort of initiating or starting the conversation. I think there's lots of misinformation. And quite honestly, I think clinicians are often just not sure what to say if we kind of open a conversation and patients have a problem and we're not really sure where to go with that. So that's kind of a Pandora's box much of the time. So given that, let's get started and really sort of thinking together about what is sexual health. And I really want to invite us to consider that this is a very broad experience, which is very much at the intersection between biology, psychology, and sociocultural experience. So this is to say that it is not only about function. It is not only about whether someone can get an erection or whether their body can have an orgasm, but it's also about how people think, how people feel, self-confidence, the experience of what's happening in relationships, the experience of what's happening when we think about body image and identity. And the reality is that if our patients hear anything, it is typically and usually only very narrow in that kind of biological perspective. I can't tell you how many times I meet with patients and somebody will say, oh yeah, I've been having painful sex and I was told to use a lubricant and it's not working. And that is such a small piece of the puzzle. It really doesn't address anywhere close to what needs to happen. So, very much want to start with this sort of broad perspective. And we're going to really talk about many of these different pieces today. I will also kind of, again, sort of additional caveat, just to sort of, again, focus our attention to the fact that actually every kind of treatment, every kind of major treatment that we bring to bear to treat cancer actually has the potential to disrupt sexuality and intimacy. I will say that we actually currently have very little data regarding the new targeted therapies in sexual health, and that is something that we have only just begun to look at. But in general, I think we can safely say that all of our treatments have the potential to impact sexuality. Also, we'll just note that the WHO only in 2006 pointed to the notion of sexual health being a kind of a human right. And I really just want to sort of bring our attention to that definition. Again, that sort of whole person definition, physical, emotional, mental, and social. And what I like about this is that they really sort of clarify that point, that we're not just talking about the absence of dysfunction in terms of sexual health, but we're really talking about an experience that allows people to have pleasurable and safe and positive experience that goes way beyond what we see in terms of disease or dysfunction. So in terms of, sorry, that's my phone. In terms of next slide, I want to really sort of think today with you about AYA sexual health in particular, and I really want to think about the idea that we're going to take a very developmental perspective, because in contrast to older adult patients who've often had sexual health sort of development and experience before cancer, for so many of our AYA patients, things get disrupted much earlier on in terms of psychosexual development, in terms of whether, when they're diagnosed, at which point in their physical and emotional identity, in terms of how this impacts where they are around decision making and identity. And this is going to be the starting point for sort of how we need to think about how to approach our patients. So, when development gets disrupted, I would say first and foremost, we really need to appreciate that all of these milestones, or many of these milestones, can be significantly impacted. So whether we're talking about at a relatively early age or in adolescence, whether people are sort of exploring their identity, having initial experiences by themselves or with someone else, whether that's dating or relationship building, often those things don't happen, right, when people have cancer at a young age. That obviously has a sort of a downstream effect often in terms of longer term relationship, partnership and marriage, family planning, family building. And the impact of that sort of missed or delayed development is both short term and long term. So we also know that when sexual experiences are lacking, we also know that when young adults, adolescents do not get the information that they need, they are often embarrassed. They're often unsure how to get started. They often will tell us that they want to be sexually active. They want to be somewhere like their peers, and they're not really sure where to start with that. I think it's interesting that when we look at survivors at a young age, let's say 18 to 28, this was one study that was done. I'll show you about another in a little while. A significant number are not sexually active at all. A couple of quotes, which I think sort of captures some of this sensibility. 26-year-old said that when she was in high school, I was too sick and exhausted to date. Now I'm in my 20s and I'm scared to date because I'm embarrassed to admit that I've never had sex. And I can't tell you how emblematic this quote is. So often we hear from our young adults, late teens, mid-20s, who will say, I go, I'm back in school, or I go out with my friends, and everybody seems to know what they're doing. And I still feel like I'm 10 years or 12 years old because I just never did any of those things that everybody else was doing when people were in high school. Other quote that I want to share is this idea, just that really sort of captures the issues around sort of misinformation or lack of knowledge that we often see. A 27-year-old said, I'm worried about having sex because I think it's going to hurt my ovary, which is really scary because I only have one left. So again, not even really knowing what's okay, what's not okay. And that's really about lack of information. So as Mike said early on, sexual health from our young adults is often sort of reported as one of the most important aspects of quality of life. Just to give you an idea of what we're talking about in terms of prevalence, more than 50% of our AYAs talk about delays in development. More than 50% talk about being unsatisfied or dissatisfied with sexuality. And I really want to underscore the point. That is the case that more than our AYAs talk about ongoing issues long past diagnosis and treatment, often 2-5 years later. So again, long-term issues that we really need to think about. I want to tell you a little bit about some of the work that we did at Dana-Farber, just to again sort of underscore what are the kinds of issues we're dealing with. Back in 2013, we have a sort of a large ongoing cohort study with young adult survivors of pediatric cancer. In 2013, we did that. We looked at about 291 folks, half male and half female, had a very sort of short survey, just 5 items that really sort of got at sort of basics around sexual function. And when we reported on that, what we found was that almost a third of survivors reported 2 or more discrete systems of sexual function, with females having twice as much than males. This past year, we said, wait, we really need to do a deeper dive into some of that. We really want to look at some validated measures to just get some more fine-tuned understanding of what kind of sexual dysfunction we're talking about. Women filled out a short form of the Female Sexual Function Index, which is sort of a gold standard female sexual function measure, an index of erectile function for men. We used clinical cutoff scores to classify sexual dysfunction. It was sort of very sort of standardized in that way. And we also very specifically looked at this notion of sexual inactivity. This is sort of hot off the press. We're just continuing to do some analysis now. Again, about 250 pediatric cancer survivors. On average, were diagnosed at around age 8, and currently we're more or less around, mean age was about 30. And you can see it was sort of a range of cancers that they reflected. And again, what I think is really notable here, about a third of these young folks report just total inactivity, not being sexually active at all. And of the remaining sample of the 175 folks who do report being sexually active, 25% of them report not just sexual bother or concern, but clinically significant cutoff scores in terms of sexual function. And that's really significant considering the mean age of this population. And so again, people say, well, why? What causes that? Is that a particular diagnosis, a particular particular, time in life when they were diagnosed. And what we really found that what this is associated with is really the sort of long-term late effects that we need to be aware of, right? Fatigue, poor physical health, poor mental health, and depression, which often track with sexual dysfunction. So, what are the common problems and what can we do about them? I really want to sort of give this as our rubric in terms of what we're going to talk about today. Certainly for women, any kind of genitourinary symptoms of menopause. So young women who are dealing with ovarian suppression, change in ovarian function, loss of estrogen, whether that's short-term or longer term, are likely to have what we call the genitourinary symptoms of menopause. We, for both men and women, see decrease in desire, arousal, change in orgasm, and loss of satisfaction. Very much thinking about body image distress, lack of sensation, loss of sensation, body integrity. People routinely talk about feeling damaged on a sort of broad existential kind of way. For guys, we often see erectile dysfunction. Relationships are stressed. People often don't know how to start relationships. People have no idea how to date. When do you tell someone? Where do you start? How do you even begin that conversation? And you can bet that all of this is not just psychologically distressing, but it really leads to avoidance. And we often see in a very systematic kind of way a kind of an chicken and egg phenomena where people are sort of avoid something that they find stressful, and the more you avoid it, the more stressful it becomes. So for any of your patients who have any kind of disrupted ovarian function, I really want you to be thinking about these genitourinary symptoms of menopause. This may be from hormone therapy, radiation therapy, chemotherapy, surgery. The issues around menopause are relevant whether someone is partnered or not, whether someone is sexually active or not. It is not just about vaginal dryness. It is often accompanied with urinary symptoms, because we know that the urinary tract has millions of estrogen receptors. And when we deplete estrogen, we often have urinary issues that may be even UTIs, discomfort, dysuria, bleeding, chafing, itching, burning, again, with or without sexual activity. So really important to appreciate that whether somebody is single or not, whether somebody says that they're sexually active or not, we really need to ask women about ovarian function. And I'm going to talk a little bit about what we specifically need to do to address those issues in a few minutes. Other psychosexual concerns that are really, again, relevant for all of our patients are just these issues around body image. Some of the concerns are obvious, and I think that we can often acknowledge whether that's hair loss or weight gain or scars, change in, short stature, lack of breast development, this kind of thing. Sometimes the body image issues are not obvious. I think it's still important that we ask about that, because the reality is that if people are struggling, and if it's not something that you or I might see, it doesn't mean that it's not something that's getting in the way of function. And again, that feeling around being damaged or broken is just often ubiquitous. This is a quote which I had to share because I think, again, so captures what we're talking about. I can only go on Zoom dates because no one can see how short I am or I'm losing my hair. I don't have to see the look on their face when I walk in and they say see that I'm not really a man. Obviously, I can't do Zoom dates forever. So I think that really pulls on the heartstrings, and you can appreciate just how people feel anxious about how to deal with some of these issues. So again, issues are not just long-term, short-term, but also long-term. I just want to say that sometimes people say, well, gosh, it's important, but the good news is people are alive. And I agree, we're all in the business of saving lives. But this is really about quality of life, and that these long-term issues with sexual function really track with other issues that are problematic. Again, anxiety, depression, relationship issues, and can often be a reason why people actually even discontinue some of their treatments because they're worried about these side effects. So I will just say quickly that we know this is an unmet need. Most of our survivors do not get what they need in their care, despite having actually a lot of guidelines, whether that's from NCCN or ASCO, that we should be talking about sexual health. And there are lots of barriers to that. Patients will very clearly say, I don't want to make my provider uncomfortable. I'm not sure how to bring it up, and I'm not sure that it's going to be important relative to everything else we have to talk about. Providers certainly get very little training in this. And there can be lots of stigma. So to be clear, what AYAs tell us very directly is they want straight talk. They want and need you to initiate that conversation. They want time alone so that it's not with mom or dad in the room. We need to normalize this conversation and to make sure that what we talk about is really individualized to our patients. I think in terms of how to start the conversation, first and foremost, what I would invite you to consider is this has to become a part of a routine review of systems. It is not more important, less important, outside of the realm of everything else that we do, whether that's asking about nausea, fatigue, anything else. It's just a part of our kind of classic review that we do. We have to have a safe and appropriate environment, and we need to just basically have a kind of a non-judgmental approach as we sort of start this conversation. That might mean asking parents or family to step out of the room, really respecting our patient's confidentiality, and again, understanding that there are sort of individual components that we need to be aware of. So whether that's gender identity, how old someone is, their developmental stage, sexual orientation, but most importantly, we're not going to make assumptions, but really with respect and curiosity, we're going to start the conversation. So I'm going to offer a sort of a checklist rubric that we can use just to sort of, again, sort of think about what are the components that we need to bring to our patients in the context of this kind of care. We really want to be able to ask the patient if it's okay to proceed with the conversation, but most importantly, introduce the topic of sexual and reproductive health. I'm not going to talk at all about reproductive health today, but I will comment that in large surveys with both directors of training programs, with physicians in general, we know that we actually spend much more time talking about reproductive health than we do about sexual health. We also know that we have to offer people the kind of basic understanding that there is advice available. We have to really sort of validate that there's help. We have to get the kind of information from our patients that allow us to help them. And then we need to think about what are the right kind of resources and follow up for them. So, again, when I say ask, I really think about starting with a ubiquity statement, something that validates the basic topic. Many adolescents worry, or young adults worry, about how cancer is going to affect sex and dating and relationships. I want to take some time to talk to you about that. Is that okay with you? Really important to open the door, give people the information and understanding that this is a topic that can be talked about, and it is not something that we have to shy away from. In terms of, again, making it clear that advice is available, again, just an example, while sex and romantic relationships are possible during cancer, there are things that are important for you to know, right? Or there are things that are important to know when you go through, changes in ovarian function. I want to sort of give you that information. So again, it may be that you're already talking about contraception or safe sex, but how much do we talk about sexual function in a routine sort of way? Often we don't. I think that in terms of assessment, we really want to clarify that we're also talking about relationships, because our AYAs say that they struggle with this so much. Being able to say something like, I'm going to ask you some questions so I can understand more about your health, so I can, this will help me help keep you healthy. Are you in a romantic relationship? Do you date? Are you interested in dating? What experiences have you had? And is there anything that you're concerned about so far? And I think it's also very okay to ask very directly, do you have concerns about anything related to sex that you want to talk about? Are there any physical changes that make it hard to enjoy or difficult to enjoy sexual activity, either by yourself or with the partner? And again, appreciating that we are not assuming it is only someone who is partnered who may be struggling. So I want to talk about this idea of what it means to assist someone. What does it mean to basically give recommendations or give treatment? We don't have time to go through all the ways that we can intervene, but I really want to focus our attention on a few things in particular, because I think that there are some simple strategies that are effective that really everyone needs to be aware of. Again, I'm going to start with loss of ovarian function and vulvovaginal health. It is really striking to me how many times young women simply do not get this information about how estrogen depletion or change in estrogen levels has an impact directly on vaginal genital tissue, also has an issue on vulvar tissue. You lose about half your testosterone when we lose ovarian function. So really being able to explain to patients that when that happens, we have to be able to return moisture and stretch or elasticity and blood flow to that vaginal or genital tissue in order to be able to make sure that tissue is healthy. I always clarify for women that this is not just about sexual activity, but this is also about being able to get a GYN exam comfortably. So this is really thinking about vaginal health broadly. In terms of some of the simple strategies, my colleague, Dr. Jean Carter, often talks about these sort of notion of simple strategies that we should all be aware of. Patients always hear somebody said, use a lubricant. Lubricants can be helpful. They stay on the surface of the skin to sort of reduce friction with sexual activity. They do not hold water in the tissue. Most women who are dealing with any kind of vaginal dryness need to be using a vaginal moisturizer, which is a different kind of product and really helps hydrate those tissues over time. That can be a huge breakthrough for somebody who's been having dryness and discomfort. And then, of course, often wants to avoid it, for example, avoid sexual activity because it hurts, just to understand what the difference is with those products, right? So making sure that they have pH in the right level. You don't want to have pH that's too high. Women are often sort of prone to bacterial infection when pH gets out of balance. Good moisturizers often also help balance pH. And really, we are very clear about products that we can offer people. We also know that sometimes women who are in sort of treatment-induced menopause, need more than a topical over-the-counter moisturizer, and we often use local vaginal estrogen. So just to say, being familiar with knowing that that's an option, whether that's something that is prescribed from your team or that you know who the gynecologist is or the urogyne who is going to be comfortable, or urologist talking about that. But low-dose vaginal estrogen is incredibly effective at addressing these genitourinary symptoms of menopause. My only quick comment is that often we put women on HRT, hormone replacement therapy, which is helpful for systemic symptoms, but is often not good enough to manage some of the vaginal symptoms. And we need to make sure that we're asking about these sort of specific genitourinary symptoms in particular. For guys, there's often a big focus on, the little blue pill or taking a PDE5 inhibitor to treat, changes in erection. I certainly want to acknowledge that we need to obviously be aware of that if needed. There are actually lots of different sexual aids for men who are dealing with changes in erectile function. I also want to comment that for many of our young men, for example, after testicular cancer, it is not just about erectile function. It is often about not feeling confident in their manhood, not feeling confident in performance, not worrying, for example, that somebody will notice if they're missing a testicle, and what does that mean in terms of body image and who would want to date me. So being able to sort of ask if people are bothered, what they're worried about, and who a counselor or therapist might be that can talk about some of that, so we are not being reductionistic with our guys so that it is only about erections and erectile function. For both our young men and women, it is really important to be aware of the pelvic floor dysfunction that we see after treatment, whether that's any kind of scar tissue and after any kind of surgery in or around the pelvic floor, whether we're talking about any kind of pelvic radiation, hormone changes. It is stunning how the pelvic floor is affected by so many of these treatments. Our patients are typically unaware. If you've had a patient who's older, who's had a baby, she's probably heard someone tell her to do Kegel exercises, which is about squeezing those pelvic floor muscles. There are 26 pelvic floor muscles, and typically with young women, for example, they become what are called hypertonic. They become too tight. They're not able to relax the pelvic floor, and people really need very specific help and coaching for that. So certainly at the Dana-Farber, we work very closely with our pelvic floor physical therapy colleagues who specifically work in the pelvic floor with men and women, and that's really teaching patients about how to relax the pelvic floor. For women, it's about very clearly learning how you can, in a mechanical way, using a set of what are called vaginal dilators, increase stretch, increase elasticity. They do exercises both at home and in the office, and this is often an incredibly important modality as part of sexuality rehabilitation broadly that is really often not talked about and is a little known resource. So on that note, in terms of that last piece about how to assist people, we really have to take a whole person perspective, and that means building a team. That means knowing your urology colleagues, your gynecology colleagues, your endocrine colleagues if you're dealing with hormone issues. Who is the physical therapist who does pelvic floor work? This is not general physical therapy. It is highly specialized, but there are people who do that pelvic floor PT across the country. And really, I would say the issue is that if you have your team in place and you have your referrals in place, it's going to be more appealing to ask these questions and have the conversation because you sort of know where to send people as they need help. And you have to follow up. So it's not just about starting the conversation, but it's about, on your follow-up visit, asking how it's going, given what you talked about the last time, and again, initiating that yourself. So in terms of validated measurement. Sometimes people say, well, is there like a screener I can use? Certainly through the PROMIS measures, there's a terrific single item screener for men and for women that's been very much validated to capture common problems for adults. I would say it is relevant for some of our patients, but it is not relevant for capturing so many of the developmental and psychosocial issues we see in AYAs. This is very function oriented, so that's an issue. Again, measures that we do have on the adult side are very much typically focused on sort of function and really don't get at some of those milestone issues. So, now is the time. I know our group at Dana-Farber has grant funding to work very much on developing an AYA specific measure, which I would say stay tuned about. And I think that there's actually more interest in this than ever in terms of creating some new measures that will sort of capture some of these specific concerns. I really only have a few more minutes left, so I'm going to speak quickly, but just to say, I am very much aware that there are so many cultural factors and issues for our gender and sexual minority patients that we just need to be aware of. We know that our gender sexual minority patients face so much discrimination as it is, and often just really do not get the attention they need. If the context feels unsafe or unwelcoming, clearly patients are not going to bring up this topic. And I would say first and foremost, we really have to gather the information for some of these issues, right? Where are people coming from? What is their sexual orientation? What's the language? What's their religion? What's their background, to help us understand where they may be coming from and to help us evaluate some of our own biases. We all have them. And I think it's just sort of being able to become aware of what those are so that we don't just make assumptions, assuming a patient is heterosexual, assuming somebody is only sexually active with another person, etc. I think that when it comes to sexual health, whether it's religion, whether it's race, ethnicity, whether it's cultural beliefs, people are all coming from a context, past, present, and future expectations that we just need to be tuned into. And I think that in particular, when it comes to, our sort of trans patients, when it comes to folks with sort of different sexual gender identity, there are so many assumptions that are made that there's really no room for them at the table, right? When it comes to talking about sex, because it's only going to be from a very narrow perspective. That just really, we just have to move past that, and we have to really broaden our minds and our hearts to be able to addressing people, I think in a curious and respectful way, but that one that in a way that allows them to be able to offer their concerns. So, open-ended questions. I'd like to learn more about your religious beliefs in terms of what kind of sexual activities are acceptable, right? Are there other factors like cultural or religious beliefs that are just important to you when we talk about sexual health? And I will often ask an open-ended question like that. And again, what do we do to signal to our sexual and gender minority patients that they're in a welcoming space, whether that's with a lanyard or a flag, whether that's making sure that we think about what the pronouns are and really sort of just apologizing if we stumble. I think we really need to signal to people that this is a welcoming and safe space. And if we're not sure, we have to do some of our own sort of studying, learning, reading in order to be able to sort of figure out how to talk comfortably with all of our patients. So in summary, we know folks don't get the resources they need because very few of us ever have any training, and we really often have little time and aren't really sure about the resources. And we know that the goal is to really increase our patients' competence and self-efficacy to manage these issues. So I think if we use a team approach, and I think if we ultimately help our patients create what I call a roadmap, an action plan for what steps they can take, it really not just affects quality of sexual health, but it really improves quality of life. And as I said, perceived self-efficacy, which has both short-term and long-term benefit. So again, let's all think about our personal challenges, whether we have blind spots or biases that we need to sort of be aware of. And let's think about those systemic barriers, right? Whether we have to figure out who is the go-to person on the team who's going to start that conversation, what is our referral network, who are our resources, who's the PT at this hospital that I can refer to, just figuring out from a systems perspective, what do I need to do to roll this into a review of systems, and what opportunities might I need to seek out for CMEs or my own education, such as the one that we're doing today. And I'm going to stop on this quote from a patient of mine, which basically says, as you can see, it's really a waste to be alive if I can't live fully. And I think that's really why we're all talking about this today. So thank you for your time. I'm glad to be here with all of you. And do feel free to reach out to me anytime. Thank you.
Wow. Thank you for that really excellent, excellent talk. A lot of really great insights in thinking about ourselves and kind of turning the spotlight on ourselves as well as outwardly to our patients, as well as some great practical ideas and questions that we can ask when we're trying to implement this. So thank you. We did have some questions. So the first one came in through an email before this session, but do you know of any specific programs at cancer institutes that have implemented to address sexual health and survivorship?
Thank you for the question. Well, I'm very happy to say in the many years that I've been working in the survivorship field, I'm thrilled to see that we have a sort of a growing interest in this area specifically. So the answer is yes. Obviously, at the Dana-Farber, we do. Memorial Sloan Kettering has an excellent program. The University of Chicago has a good program. There actually are a number of programs now who have who are trying to embed resources, I would say, within their survivorship programs around sexual health. It is not anywhere close to being, I would say, good enough. But I would say that we have a number of programs that are sort of starting to attend to this. And I think that that's something that we're going to continue to see more of.
Thank you. And it looks like I think we might have someone who raised their hand if you want to unmute yourself.
Scott, is that something that I do?
No, they should be able to unmute themselves, but while they're figuring that out, I can ask some of the other questions that are in the Q&A.
Hey, Scott. Sorry, it's Nick real quick. They can't come off of mute since we're on webinar.
Oh, okay. So whoever raised their hand, if you please type your question into the Q&A and I will ask it for you. So one question that another attendee had is that they said they struggle with is how to approach these discussions based on age within the AYA age range. With patients that are minors, I feel more hesitant for some reason mentioning these topics, but feel it's a missed opportunity.
Yeah, I so appreciate that question. And I mean, I think any of us who are working in this space know that, the experience of a 15-year-old is often very different than the experience of a 25-year-old. And I'm not in any way assuming we're going to paint with one broad brush. But I will just say, you would know this better than I do, but many of my colleagues shared with me that, when you're a pediatrician, right, when you're doing pediatric training in general, you sort of learn a little bit about how to talk with young adolescents and teens about, general questions about sexuality. So I think it is actually more than okay to say to a 14, 13, 15-year-old, gosh, lots of times young people have questions about how these treatments affect their body, how these treatments affect, thoughts or concerns about sex or sexuality. I'm wondering if you have any questions for me that you'd like to talk about. So that is a sort of a broad and open question. It doesn't assume that they have sexual activity or that they've been sexually active. But what I would say is that, lots of you can bet that most young people, right, starting by the age of 10 or 12, have all kinds of things on their cell phone that are all kinds of ways connected to sex and sexuality one way or another. So it's not as if you asking this question is the first time they're hearing that term or being asked a little bit about their bodies. So, in a way that are asking them to think about that. So, you're talking about, and I think in a cautious or careful way to be able to say lots of times, young people have just questions about how this is going to affect how this affects their bodies or how it affects how your body might function or, I'm just wondering if you have any questions for me. And we think about that in terms of, whether that's just about sex or about dating or being with another person. And I would really leave it in a kind of an open-ended sort of way.
I'm going to sneak a question that piggybacks after that comment, if that's okay. So many of us oncology providers, we receive training in communication and communication skills, and we have a lot of behaviors to model in regards to talking about diagnoses and prognoses and treatment. I can say personally, and then based on what you mentioned in your prior training, many of us do not have sort of that modeled behavior on how to talk about sexual health and how to bring up these issues. You did a fabulous job sharing some tips and tools, but are there any other resources or other opportunities for us to practice these behaviors or communication?
I so appreciate you asking that question, and yet that's another grant that I've been working on, Mike. So yeah, I think we need to have resources available. But I will say this, even if it's just with a friend or a colleague practicing, how to pick a couple of these questions. The most important thing I would say is that if you just try it out with a few of your patients and you see what you get back, overwhelmingly, I assure you, people are going to be relieved that you're asking, and it becomes a kind of a self-reinforcing experience, right? Like, you may need to start with, I'm not saying with every patient if it's something that you never asked before, but I mean, even if you just start by saying, gosh, lots of times people have some concerns about sexual health in the context of all this stuff that we're talking about today, wondering if there's anything that's on your mind, and just notice that the patient doesn't look at you and go, oh my God, but says, oh, thanks for asking. That's reinforcing, right? That's practice. So I think that, it's a really important question you're asking, is like, why don't we have good models for this? Why isn't this rolled into all kinds of other ways that we learn about communication? And say my quest would be that we find ways to do that in a more systematic way. But I would say just even starting with practicing with colleagues and friends, and then saying, okay, this is one question I'm going to start by asking, and really noticing that people are overwhelmingly usually quite glad that you asked. And I think that can be itself motivating to try that the next time. You know what I mean?
Yeah, I appreciate that. And you're getting some feedback in the chat that folks really appreciate the language that you're using and being able to model the communication that you're sharing with us here. So thank you.
Thank you.
Another question that was in the chat is kind of related. While we were just talking about more about communication, are there specific training programs for professionals who want to increase their awareness or knowledge of sexual health concerning AYAs?
I'm so glad that you're asking. There are, again, this is something that when I started in this area, like there wasn't, I think that there are bits and pieces. If you're asking me, is there a specific training program that sort of covers all of it? Not that I'm aware of, but what there are within organizations, right? So within the, we have a wonderful organization, the Scientific Network on Female Sexual Health and Cancer. Okay, if you Google network, cancer, and female sexual health, you will get to our website, and there is a plethora of information and resources on there for both patients and providers. I would say through all of the major sexual medicine societies now, Sexual Medicine Society of North America, you can find modules online, pieces of training. I don't think that there's like one program, but what I would say is that if this is something of interest, there actually is a growing number of resources around sort of cancer and sexual health that people can access.
Thank you. And I guess this is a personal or a question that I have about similar on the same line, is that, do you know, or have they looked at who patients want to hear this information from? That,
yeah,
yes,
they have.
They want their physicians to ask the question, but let's say they need to take action or to treat them. Do they still want their oncology provider to do it, or to be referred to a specific sexual health provider?
Yeah, no, I think that's a great question. I don't think anybody expects oncologists to be sex therapists, and I don't think patients would expect that any more than they would expect you to also be a dermatologist and an oncocardiologist and a nephrologist at the same time, right? But what they do is, and what they do want, is you to normalize the topic, start the conversation, ask what it is that is a problem. And I want to clarify, I didn't have a slide on this. A problem is anything that's distressing to you, right? So I'm not coming from a place of telling a patient what is normal. I'm coming from a place of being curious to ask, is there anything that's changed or on your mind that's bothering you, right? And if the answer is yes, it deserves some attention. And what I think that they want from the oncologist is, one, to be able to normalize that, yes, this is related to treatment in some way, right? This isn't out of the blue. And two, there are resources, there's help, you're not alone, and then three, to be able to help them get to somebody who might be able to do some work on that. And I appreciate that sometimes, that might mean saying to your patient, I'm not totally sure who to send you to, but that's okay, because I'm going to get back to you on that, right? So not, being able to, you don't have to have all the answers in the moment, but you are basically saying, I'm going to partner with you to make sure that we get you to where you need to go.
Sharon, one of the slides, or one of the many slides I really loved and learned a lot from, was assembling your sexual health management team. So being prepared. Yeah. Many providers feel very uncomfortable because we don't ask questions that we don't know what to do with the answer. So that your point of thinking about who will you refer, males with these issues or females who have these challenges, what is your next step so you can be prepared. So when you do get that response, which is expected because so many of our patients face these challenges, you actually have those sort of, steps 2 and 3, or at least steps
Right.
1.5.
Right. And the other thing, Mike, I'll just add to that is that it also is helpful because sometimes when nobody talks about this stuff, like everybody assumes that maybe it's someone else is dealing with it, right? So like I will see young women sometimes years after a certain treatment, after let's say bone marrow transplant, right, where nobody has ever circled back to giving them, let's say, vaginal estrogen, and they have been struggling for years with, pain or discomfort, not because anybody would disagree with that, but just like it wasn't on anybody's one list to do it, and nobody does it because everybody assumes maybe somebody else is dealing with it, right? So just making sure that it's in a review of systems for somebody, and often just starting in a kind of survivorship oncology context allows us to make sure that somebody's going to be attending to those issues.
And then we also had a few questions about resources. If you could share either now, or we can also post them on the on-demand site of our website and our repository for general resources on sexual health, but also specific products that you would recommend for patients. Like one person was commenting on that their cancer center has a boutique that sells sexual health products. So any recommendations about those?
That makes me happy to hear that, Scott, because for a long time we were the only place who did that, and the people at the time thought I was a little crazy 15 years ago asking the Dana-Farber if we could get vibrators for the boutique. I can't even tell you the feedback I got on that, but I will tell you that I'm thrilled to hear that. So I think the best thing to do, if that's okay, I will send you, because we have a number of teaching sheets and resource sheets that we give our patients, and I'm happy to share that with you guys to post that. Yes, happy to do that. Sure.
I have to add in and ask the question whether the sexual health products have the cancer center logos, but you can choose to add that or not.
That's funny. Well, even on that note, this actually coming weekend, ASCO has a quality symposium. There's a quality care meeting for ASCO that's going to be in Boston this weekend, and we actually have a presentation that we're doing there specifically about sexual aids, right? Because you look at the guidelines that say, recommend this, recommend that, broad categories. How do people possibly know what to pick or how to choose? So we actually did a little bit again of a deep dive into helping people assess what are the right kind of sexual aids out there. So happy to share all that. Yep.
Thank you. And then another question that was in the chat, it's going back again to communication and thinking about patients who are minors and in pediatrics, but any advice if you have parents that are hesitant to leave the room and how to still continue to have that conversation and move that, open that up to the discussion?
Yeah, so I would. That's a great question. I would love to hear from Mike and Scott on that too. It's about talking about anything, right, that may be uncomfortable with parents in the room. That's also relevant when you're asking, I would imagine, about things like alcohol and drug use, right? It's sort of a similar issue. I think that what I tend to advise is saying, we're gonna talk about a few things right now, including about sexual development and sexual health. I suppose that you can't make a parent leave the room if they refuse, but I think that at least you can say in front of a parent, just want to acknowledge that lots of times, development and sexual health can get disrupted or impacted by treatment. That's something that I'm happy to talk about today. It's also something that I'm happy to talk about at another visit. But I just really want to sort of acknowledge that and see if you have any questions. It may not be something you can deal with in the moment, but at least it sets or plants that seed to the patient that you're a safe person to talk about that, and that they can reach you or reach out to you or talk with you another time. I don't know, Scott, Mike, do you have any other thoughts on that?
Yeah, no, I think, I agree. Sometimes it's about being creative, taking other moments if the patient happens to be alone to kind of swoop in there. But also, as we were talking about earlier about your team of professionals, that there are many other people as part of our team that sometimes do have more of a luxury, or families feel more comfortable allowing them to have one-on-one time with our pediatric patients, whether it's our social workers, our APNs, or nurses, and kind of utilizing those other people as part of the team, and empowering them to help ask some of these questions and open the door to discussions, and sometimes gather some of that information, which then later you can say, I know that you had some questions you wanted to ask me personally. do you mind stepping out? And or maybe, like you said, think about it for another visit.
Yeah,
Yeah.
and Sharon, I'd love to sort of go up in age a little bit and think about communication with partners and perhaps the frustration or guilt on both sides. This is something I bring up with my patients. I don't know what to do with other than say, talk about it, because just talking helps. But any thoughts on, how we should be broaching the subject either with partners or just how to counsel patients to communicate these challenges with their partners?
Well, sometimes, again, good question. I think sometimes people just need language, right? Like in the same way, it's just really helpful to sort of, so I will often give patients some example language, right? So you might say, because patients will say sometimes like, I feel so guilty, but I don't know what to do about this, or partners like, I don't want to hurt anybody. I don't know where to start. So I will say, listen, what if you actually just said to your partner, this is something that's on my mind. I know things are not the way that they used to be. I'm thinking about it. I don't know if you're thinking about it, but I'm wondering if we can take some time to talk about it. Full stop. Just give people that idea that you do it in a staged sort of way, including that you start by just acknowledging it's something on your mind. Could we talk about it? Right? As opposed to like, what's the question that I spring on you at 11 o'clock at night, which is not a great time, right? But it's sort of being able to sort of start by, again, acknowledging you're thinking about it, acknowledging it's a thing, and can we find some time to talk about it? And then overwhelmingly patients will say, partners are like, yeah, it's on my mind too. I'd love to talk about it, right? So you sort of then start there. And then I think next question really, again, is a way to sort of say, I know that I want to share a little bit about my experience, and then I want to hear what your experience has been, right? And again, giving people some of the language for how to start the conversation. These are not sort of sophisticated sex therapy or tips or tricks, but they're really just ways to sort of give people a sentence or two that they can use, right, as a way to start. And what I generally have found is that if people are in a healthy relationship, right, where partners really care about each other, people are creative, right? People often, I talk about how, you need to date again, right? Partners need to find a way to kind of create a new repertoire and to be able to sort of figure out what are some things that may be similar, and given how things may be different, what do we need to do differently? And how do we take our time and experiment together and go slow, right? But again, I would say you don't want to like spring something on someone. You want to sort of set the tone and ask if you can talk about it, and then really sort of dedicate a little bit of time to doing that.
That's so helpful. Thank you.
We had another question in the chat. Have you ever run into a situation where referrals are placed for younger AYA patients for sexual health and development, but parents sway them away from the service, or the patient denies a referral because they fear their parents will see their charts? How to support the patient through that dynamic?
Right. So again, yes, that it can happen, right? That's obviously frustrating. I sort of see that as, one of the many things that we all have to kind of manage when we're dealing with patients that are minors, right? And appreciating that it may not be as direct a way in terms of helping them as you had hoped, because there might be a parent saying, sorry, I'm not going to let that happen. However, I would say, to your point, Scott, there are probably other ways that you can reach your patient by letting them know. For example, there are a lot of resources online right now, right? Like all of the AYA websites have an enormous amount of information, including elephants and tea, about about this topic, right? And I would say, in terms of, you're not talking about going behind someone's back, but you're talking about letting people know there are lots of ways to get help and support and resources in the world, right? And some of that may be in kind of a traditional referral-based way where you have to go with or through parents. And some of that, again, I mean, most young people have access to a phone, to internet, to computers, and you can bet that it's a wide world out there. So, you want to be able to at least direct them to high-quality resources where they're getting good information. And I would say, it's a process, right? It might also be that it's something that's not going to work today, but maybe in 3 months or 6 months that changes. So not to give up, right? Not to say I tried and I can't address that again. I would say continue to come back to that in a regular way, but also to be able to allow, I would say, our young adults or young people to sort of just know what the resources are, including those that they can access independently.
Get nervous when Kayla comes on because it means we're at the end of our session. But before we do close, I just wanted to say, Sharon, that this has been a phenomenal talk.
No, thank
I
you.
know our audience has learned so much, me included in that audience. So thank you so much. This topic is so important. It is an area of confusion, discomfort, concern, and you've filled so many gaps just in this short period of time.
Well, thanks for having me. It was really a pleasure to be here with you today.
And on that note, we will be posting all of the resources on the website. Sorry, Kayla, if I'm stealing your thunder about this. So please check out the website, and we will send an email out when everything is up there in terms of landmark articles, resources, tip sheets, all that kind of stuff. So please look out for that and definitely take a look at those resources.
Yes, awesome. So just to reiterate, thank you from all of us at Elephants and Tea. Dr. Bober, that was amazing. We just appreciate that so much. And I know the conversation could continue, I'm sure, for hours about this topic. Thank you to Dr. Roth and Dr. Merdler as well, and the rest of the AYA Oncology Education working group for putting AYO Power together and helping with all of this. Lisa has been dropping some links into the chat. We would love for everybody to fill out our post survey. It really helps us, and there's an opportunity to also offer some suggestions for further topics that those might be interested in as we continue to roll this out. Our next session is also scheduled for November 15th. We will be doing oncofertility with Dr. Leslie Appia at 2 p.m. Eastern, so the registration is there as well. And one very final plug for Elephants and Tea itself as a resource for you, everyone on this call, for your patients. We do not shy away from stories about things that are considered the elephants in the room. So we would love anybody to check out our webpage as well for a resource. So thank you again to everybody being here, and we look forward to seeing you again next month for our next topic. Thank you so much.